Extra-pulmonary TB in 10 minutes. So, introduction wise, remember that tuberculosis was actually the airborne communicable disease and world leading cause of death from a single infectious agent before COVID-19. India contributes to about 28% of TB cases globally, and a huge amount of it contributes by the EPTB. So, remembering this is what is called as the tip of the iceberg, meaning that actually EPTBs are what diagnosed, and the number that I just mentioned is only the tip. Major problem is not even known in the society. That is because the clinical manifestation of EPTB are very non-specific. It can mimic any other disease. Second thing is it is possibacillary in nature, and sample collection involves invasive procedure like CSF analysis or hysteroscopy or doing a pleural biopsy. The organ involved in extrapulmonary TB, they are spreading through lymphatic system and hematogenous system, and it can affect any part of the body literally. So it is the brain, which is tuberculoma, meningitis, TB pericarditis, TB pleural effusion, TB lymphadenitis, adrenal TB, genitourinary TB, bone and joint, which is commonly called as the POTS disease, skin tuberculosis, and also the most important one, pulmonary TB. So diagnosis, remember any diagnosis that we go first is the clinical suspicion. Second thing we go for it is a microbiological confirmation. Third is histopathological examination. And the rest of it is supportive diagnosis as per the system involved, which also includes lastly HIV test and tuberculin test. So clinical suspicion, whenever there is a significant weight loss, persistent fever for 2 weeks or more, night swift, and obviously the organ involved will have the symptoms as per. Like in cases of pericardial TB, there is shortness of breath, and abdominal TB, recurrent diarrhea, brain TB, disorientation, spinal TB, neck stiffness, bone TB, pain, and joint swelling, and swelling of the lymph node in TB lymphadenitis. So second thing is microbiological confirmation, which can be done by CBNAT, which is nothing but cartridge. This is the cartridge-based nucleic acid amplification test, or we can go for an acid-fast staining or ZN staining, where we are using one carbylfuscin stain and a counter staining by methylene blue. To make this process a little bit faster, we can use a fluorochrome stain of sputum. And we have to also send for a first line and second line LPA to decide whether it is MDR or a non-MDR TB. Then we come about is the definitive and a gold standard for diagnosing tuberculosis or extrapulmonary tuberculosis, which includes culture. Initially, it was the Lowenstein-Jensen, which rough buff colonies, which used to take about 8 weeks, but now the process is faster, which we use as a liquid culture called as NGIT culture or Mycobacterium growth indicator tube. This fluorochrome basically detects the oxygen utilized by the Mycobacterium tuberculosis. It is directly proportional to the amount of oxygen used, which is nothing but the fluorescence here. The last thing which is very important is the histopathology. If you look at the gross specimen here, we are seeing the white caseous necrosis. We are seeing here a cavity, and this is what the millet seeds representation is in cases of miliary tuberculosis. So the basic idea is that there is a caseous necrosis followed by Langerhans surrounding it. Epithelioid macrophages will be surrounding, and the lymph nodes and the lymphocytes will be surrounding it. This is most of the time the confirmatory for diagnosing extrapulmonary TB. Third thing is the detecting latent tuberculosis or detecting a supportive diagnosis for our extrapulmonary TB, which includes MANTO, which is nothing but delayed hypersensitivity reaction to the purified protein derivative. This protein is injected intradermally, and then we look at the induration. So most of the time, for most of the individual, it is 10 mm, but it can vary for people who have HIV and immunocompromised and for children. Problem is that false positive can be there in cases of BCG and NTM, meaning if all the individual vaccinated with BCG or infected with NTM will be positive. False negative in immunosuppression. IGRA test.